I'm Stephanie Shelton, and this is episode 44 of Conversations on Health, How We Get There. It's been a while since we did the episode on women's health. You can tell by the number, episode 29. Since then, quite a bit has changed about the management and treatment of menopause. No, sorry, there's still no way to make menopause disappear. But I do think it's time for an update. There have been many new drugs approved for menopause symptoms, and after new studies, hormone replacement therapy is again being prescribed, often in the form of a simple patch. Dr. Michelle P. Warren kindly agreed to come back to talk about all this. She's a distinguished New York physician who specializes in both endocrinology and gynecology and has spent her lifetime focused on women's health issues. In 1997, Dr. Warren founded and remains the medical director of the Center for Menopause, Hormonal Disorders, and Women's Health at Columbia University Medical Center, where she is the Wyeth Professor Emeritus of Obstetrics, Gynecology and Medicine. Full disclosure, I have been her patient for many years. Michelle, thanks so much for coming back for this update.
Oh, it's a pleasure.
I kind of want to start where, or at least my use of hormones left off, which is the 2002 Women's Health Initiative study that started this rush away from hormonal therapy during menopause. So if you could just summarize what happened and then what's happening now that suddenly it's okay to use hormones.
Right. Well, I first want to say that I haven't changed since 2002 in terms of what I said about hormones. So basically, they came out with a very large study on women in the United States and a list of possible problems associated with hormone therapy. So there was a small increase in breast cancer after 5 years of use, and also a small increase in heart attacks. And what happened is that everybody panicked. Because of the way it was reported, it caused a lot of anxiety because there were a lot of women taking hormones and who were worried they were going to get breast cancer or a sudden heart attack, which was, to some people, even more scary. So, but the risks were tiny. They were less than 1%. 8 women per 10,000 for breast cancer and approximately the same for heart attacks. And then over the course of the next few years, it became obvious that if you started hormones at the time of menopause, there was no increase in heart attacks. In fact, it protected the heart. The problem was that the study was organized to look at heart attacks. And in order to get heart attacks in women, you had to include a lot of older women. So some of these women were starting hormones at 65, which is not what we did. But of course, they were included in the analysis. And in that group who had not taken hormones since menopause, there was a small increase in heart attacks. In terms of the breast cancer, that scared a lot of people. We think now that the hormones are not causing the breast cancer, but that they, if they're on hormones, it may grow faster. And that these women who in fact did develop breast cancer probably had a small focus that was encouraged to grow during the 5 years. But it was very, very small overall. Anyway, then we had a generation of women too scared to take hormones who suffered terribly. The new data shows that if you suffer during menopause and don't get treated, you're more apt to have problems later in life with heart disease. So it's not a good idea to suffer. And all of a sudden, it became obvious that the heart attacks could be managed by giving women hormones at the appropriate time, and that the breast cancer could be surveyed carefully by encouraging women to get mammograms every year, and not including women who are at high risk. So all of a sudden, a lot of women became interested in being treated because there was a downside to not being treated.
Yeah.
Um, and there were a lot of good reviews in the press about the benefits of taking hormones and the fact that you were protected from heart disease and osteoporosis. So there's been a complete switch. In fact, women who probably shouldn't be on hormones are asking to be on hormones now. So, it's an up and down thing. It's neither taking hormones, it's neither yes nor no. No, it has to be individualized for every patient. But
That's what it seemed to me when I was looking at the studies and everything, and reading some of the articles written. And that was prompted by, I never heard of an estrogen patch until suddenly they were in short supply, and, the drugstores didn't have enough of them and people were panicking. So and then I went and I looked, and it's just what you say. It's very individualized. And for each woman, there's a different way of doing it. And a lot of it had to do with lower doses and a different formulation, I think, of progesterone. Is that?
Yeah, I mean, uh, there are different ways of taking hormones, as you mentioned. There are patches and gels and pills. Um, there is some data suggesting that taking it through the skin, or transdermal, as we call it, is probably a little bit safer. And a lot of
Why would that be?
because there's a small decrease in the incidence of clots. And clots are very scary. If you get a clot, particularly in the lung, or if you get it in the leg and it travels to the lung, it can kill you. Um, and in fact, that was not emphasized in the study in 2002, but it was shown to be probably the highest incidence of problems. So um, you have to understand that taking it through the skin is probably better for certain people who are at risk for those clots. But all of a sudden, everybody wanted to take it through the skin. And patches were the most common way of taking hormones. And we have had a recent shortage of patches, partially because more women are using hormones, but also I think it may have something to do with the tariffs. A lot of these drugs are made in other countries.
Right, right.
And, we must have 4 or 5 calls a day about we are out of patches. Can you prescribe something else? So what I'm doing now is switching to a gel. You can take a gel that you apply every day. The patches are changed twice a week, so that's convenient for some people. But you can use a gel through the skin, and those
Well,
are
you
available.
like rub it in like you would for a painful joint or something?
It's a tiny drop. It comes in a package that looks like those individual packages of ketchup.
No.
Uh, and you just tear open the patch of the package and put it on your thigh once a day.
And rub it, or
Okay.
just,
Yeah, you rub it in. I mean, you have to do it. You don't do it before a shower, and it takes about 15, 20 minutes to be absorbed. But it's well absorbed through the skin, and it doesn't go through the liver. So it has advantages, taking it through the skin. Um, and the shortage, I think, is going to be a temporary thing of the patches.
okay, okay. So, what else about taking estrogen has changed?
Well, in addition to the way it's taken, I think we've come to realize that it's a safe alternative for treatment. Now there are new drugs that are not hormonal that even patients who have breast cancer can take because that was the estrogen sensitive cancers left a large group of women suffering. And there are new drugs now that are available for those patients. So I think it's encouraging. Um, it there are many benefits to being on hormones, including protecting the bones. Um, and the drugs that we use to treat patients who have lost bone, once you're on them, you generally are on them for the rest of your life. And in women who are young, we prefer to use a more natural treatment, such as hormones, rather than go to those drugs. I think people are leaning towards using hormones more liberally. The problem that we have is that the medical community is still wary. A lot of doctors will say, "I don't do that,"
Mhm.
and or they've gotten no training. So you have to find a doctor who's menopause friendly, and that's not so easy, particularly if you're in a rural area.
Yeah.
Uh, some of those patients are going to online treatment centers. Uh, I don't particularly approve of those because I think there are issues related to dose sensitivity and health that have to be watched very carefully, particularly bleeding. So,
So that it essentially says to me that I mean, I found you, and I never hidden this, that you were my gynecologist. This is how I came to know you. That I found you through a doctor recommended by other runners who worked in Pennsylvania, which was
really?
helped me in New York. Yeah, I completely forgot her name, but she was written about in Runner's World and talked about for runners how the estrogen replacement would help. And I said, "Do you know anyone in New York?" And she said, "Yes," and she recommended you.
Oh, interesting.
But but the point being, I couldn't just go to any old gynecologist in my area. I had to search around for someone like you
Mm.
know. And I think at the time you were running too, which made me feel better about you. But I mean, I had to look, and I had
Yeah.
the ability to do that. I'm a researcher. What about a lot of women now, younger women in particular, they're not even going to doctors. They get their medical advice through influencers on, Instagram, who are just other women like themselves who tried stuff and are recommending it. Um, it seems like it's more important than ever that you have to learn how to search out the right person for you to go to for your situation. And how do
Mm.
we make that easier for women?
Well, there is North American Menopause Society.
Mhm.
They have a website called menopause.org, and you'll find at that website doctors who have taken extra training to address a menopausal treatment. So that's the first thing I recommend. I think there's a movement now of multiple disciplines to learn about menopause, including the endocrinologist. And right now, the fellows from Cornell are coming to the office to learn about giving hormones because they feel that their training needs to be expanded to that. So there's an interest. And I think that eventually we'll have enough doctors, uh, hopefully in most places, who can address that issue. But the first thing I would do if I was looking for a doctor would be to menopause.org and look at the list of doctors there who can help you. There are also nurse practitioners who are trained, and
Mm.
some of them are very good because they've really uh, emphasized that in their work and have become very good at treating menopause.
All right, well, I'll put that in the show notes so everybody will have the website.
Yeah.
What about regardless of all these breakthroughs with hormone treatment, there are women that can't take the hormones, right?
Right.
What's for them now?
Well, there are two new drugs on the market now who that can help with hot flashes, and one of them is called Verosa. That's the brand name, and Linkette is the other one. They both affect an area in the brain that controls temperature. And hot flashes, we've learned about hot flashes and how they work. And there's a neuron in an area of the brain called the hypothalamus. And in that area, there's a neuron called the candy neuron, spelled KNDY. And that is very key in determining whether you're going to get hot flashes. And what happens is that particular area uh, is affected when the estrogens fall. And the neurokinin, I don't want to get too technical, but in any case, um, the area goes crazy. And you can block that craziness with these new drugs. So both of these drugs have been found to be effective. The problem that I have in my practice is that you have to go to a fair amount of work to try to get it approved for a patient. But generally, it gets approved. Um, and then there's another problem is that they found that certain people, a small number, there may be liver issues which develop. So you have to measure liver hormones when you start, and 3 months later, probably for maybe a year, every 3 months. So it discourages a lot of
Yeah.
patients,
Yeah.
but they work well. And I think that they've been very helpful. Um, Antidepressants will also help a lot.
Really?
Yeah, Paxil in particular has been approved for use in menopause. Um, it doesn't treat all of the problems related to menopause, but it will help reduce hot flashes, and that's been well shown.
If you're now taking the HRT or even these other drugs, and you happen to have an extended menopause where the hot flashes and the night sweats and all of that just go on, is there a limit to how long you can take hormone treatment or any treatment? I mean,
Yeah.
why do you just have to suffer what's left?
Uh, well, that's a good question because I get asked that a lot. How long am I going to have to take this? And the average use is 2 to 5 years. However, around 11% of women have hot flashes forever, and they suffer. Oh dear. Uh, yeah, and
Still.
they have trouble sleeping, and it causes anxiety. So I'm very liberal. I will let patients, as long as they promise to get mammograms once a year, and there are no other contraindications, they can take hormones, and I don't take them off. I'm also very careful with patients who have mood issues because the hormones can really help. It may not be 100% treatment, but it does help tremendously. And when you take away hormones in that group, I call the women hormonally vulnerable.
Mhm.
Um, they can go into a fairly severe depression. And so I'm very careful and I work with them about the issues repeatedly. And I have quite a few patients who are in their 70s and 80s who are still on hormones because they they're suffering.
Okay, there's another thing that happens in menopause, not to all of us, because it didn't happen to me. But you gain weight around your waist.
Yeah.
I was running marathons then, so I'm not, an average person. Um, is it, you mentioned this very much in passing when we discussed this before, just over email. But the GLP-1 drugs, which are now being used for almost everything, it seems,
Right.
are they worthwhile for blocking this weight gain?
Well, I don't know if you can block weight gain, but I do use them in patients who have gained weight and who are showing signs of problems related to that. The first thing that tends to happen is that their blood pressure goes up and they need a
Mhm.
treatment for blood pressure. I will use it in that kind of patient. Yes, they work, um, and I think they're nothing short of a miracle for certain patients who have never been able to control their weight before. They have to be used carefully because not everybody should be on them. You can lose bone. The bones don't like it when you go on a diet. And so, um, in women who have osteoporosis, I'm very careful about using that drug. But in general, they work well, and in my experience, they don't necessarily have to be on them forever. They can you can use them to lose the 20 pounds that you gained, and then maybe take it once in a while when your weight starts to creep up. But you don't have to take it every week the way they're given to patients who are very overweight. The other thing that I find so interesting is that there's an anti-inflammatory effect, and some patients have noticed that their migraines go away.
Huh.
So we're just beginning to understand how these drugs work, but that's a great side effect.
Yes.
Yeah. So, and migraines are a big problem for certain patients at menopause. So I use them carefully, and I think they're very helpful. And as you say, the central obesity, the weight gain around the waist is very hard to lose. But these drugs do work.
So just to kind of wrap this up, unless there's something else we didn't talk about that's changed in the year and a half or so since we talked the last time on the podcast. First of all, I should ask you, is there anything else that we should be talking about?
Well, I think we've more or less covered everything. I think we're not so worried about using hormones anymore. And I think that the main thing to remember is that you shouldn't suffer because it's not good for your heart. But other than that, those are the big um, changes.
Certainly seems like a huge gain to me, anyhow.
Yeah.
Um, the final thing that I want to talk about a little is I've begun to see a number of discussions to the effect that women are afraid to talk about menopause at work and try to get some accommodations if they're having real problems. I mean, we've done it for pregnancy, we've done it for nursing mothers, but they just kind of draw that line. It's still almost the hidden thing. Can there be anybody in the entire world that doesn't know that women go through menopause?
Well, I think women are afraid to talk about this because to them it's a sign of aging, and they don't want to admit, particularly at work, that they're aging. Um, it's sort of too bad because it helps a lot to be able to talk to other people about their symptoms and to seek the appropriate treatment. That's going to take a while before people are willing, particularly at work, um, to talk about menopause. I mean, there are a number of studies which show that the incidence of women retiring it increases dramatically at 50.
Yes.
So women go into menopause generally around 50 plus or minus 2 years. So I think there's a correlation with the onset of those symptoms, that's particularly related to this tendency to just give up and retire. In my mind, a woman at 50 is at the height of her career,
Yes.
and she should seek treatment instead of quitting. So, yeah, but it's very hard to work when you can't sleep. And you get up at a meeting and you suddenly turn red and start sweating, and it's embarrassing.
Mm.
And so, for many reasons, I think it's important to find somebody sympathetic who's trained in menopause treatment and to get treatment.
So I think the bottom line to all this is that, and it's got to be us women, we have to really keep talking about this so that it becomes as normal to talk about menopause and its problems and how they can be solved, as it is to talk about what kind of drugs you can't take during your pregnancy or that you can, or, what a nursing mother should do at work to get a nursing room, or a room to, harvest her milk. It just seems it's just pushed under, you watch television and television news and you see very little discussion about it. So
Yeah,
there has to be pressure from us,
yeah, yeah, I agree completely. And there are solutions, so
Yeah.
even more of a reason to talk about it. Um, and the number of women that I see who are told to just tough it out is terrible.
Try
So
telling a guy that. Just tough it out.
yeah, exactly. So I hope things will change. I
Yeah.
mean, you're talking about it. I'm talking about it. I've talked about it for 20 years. And maybe as the younger generation of doctors get more educated about this, there'll be a turnaround.
Well,
Um,
I do think among younger people, there's more discussion of everything now. I mean, there used to be subjects that were just not polite to talk about. There's no such thing anymore. So it doesn't matter what it is, you can talk about it. It's just the question of whether the other person is knowledgeable or interested. So, like
right.
you say, with the younger generation of doctors who are at least getting some training, the fact that they're coming to your office to observe how you do it is a really good sign.
Yeah, yeah. Well, I read in the Times years ago that somebody turns 50 in the United States every 10 seconds.
Mm.
So it's a huge demographic. And it's a demographic that's been ignored for quite a while. But I think it'll change because the generation of women that are going through menopause right now are more open and more
Right.
educated, and more willing to talk about it. And some people have even made careers about talking about it. So,
Hopefully
um,
with the right information.
oh yeah, well, that's always an issue. But I think it's going to change.
All right, we'll leave it on that hopeful note. Thank
Yeah,
you, Michelle, for coming on the podcast again.
it's a pleasure.
Dr. Michelle P. Warren is a distinguished New York City physician who specializes in both endocrinology and gynecology and has spent her lifetime focused on women's health issues. In 1997, Dr. Warren founded and remains the medical director of the Center for Menopause, Hormonal Disorders, and Women's Health at Columbia University Medical Center, where she's the Wyeth Professor Emeritus of Obstetrics, Gynecology and Medicine. Links to the websites she discussed are in the show notes. Now, Next month, episode 45, will continue to explore the rapid integration of AI into healthcare, specifically now the U.S. healthcare system. We'll be talking to Raquel Moore, Optum's Vice President of EMR Strategies and Special Projects, about how one of the more advanced digital patient portals, which you may already be using, is being expanded to give your doctor immediate access to your medical charts if you're hospitalized. Plus, a lot more about where we're going with AI in the U.S. and how. Episode 45 will drop on the third Tuesday of June. As you know, I schedule one new podcast episode a month. And if you enjoy the podcast, please follow us or subscribe and share. The video version's on YouTube, audio on Apple, and on all the other major platforms, including my host platform, the Podbeam website and app. Show notes and links on my website, stephanieshelton.com/conversations. Now you take good care of yourself and all those you love, and I'll see you next time. Conversations on Health, How We Get There is produced and edited by Frank Harold. Research assistance from Dr. Richard Saltman, Professor Emeritus of Health Policy and Management, Rollins School of Public Health at Emory University in Atlanta.